I'll be speaking quickly about all inside meniscus repair. So usually I'm more, I favor inside out more than all inside. That's my always first choice. Usually only in the posterior region if I go for the all inside. So again, greetings for from IAS. Sincere request to become a member if you are not a member of Indian Arthroscopy Society. So how do, as already very well said by Dr. Sachin Tapasvi, how to choose which type of repair you are going to do. So as shown in this picture, so the zone which is shown here in the red color, so that's where usually it is recommended all inside. Blue zone usually can be managed very well with inside out, and green zone can be done with the outside in, whether for it is medial or lateral. So when you decide about all inside repair, so it usually reduces surgical time. There are no external approaches or incision needed. Everything is done inside the knee. Accessibility to tears of the posterior horn region is very easy with this all inside repair. So these are the various companies commercially available self-adjusting devices where anchor is loaded into this needle, and then you push it in, deploy it behind the capsule, then withdraw, again put it at different place, and again do it the same way. So studies have shown there is not much difference between both these uh, techniques, all inside or inside out. And when you decide about this all inside, so you need to be careful about this posterior neurovascular bundle. So when you look at it, it is just behind the root of the posterior root of the lateral meniscus. So that's where is the popliteal vessels the lying. So you need to be very cautious, and it is almost say within 18 to 20 millimeter from the posterior root of the medial lateral meniscus. So there are various trajectories. So when you are planning to do all inside repair, so depending upon which company implant you are using, so there are various angled devices, or there are devices which can be angled as per your convenience, so that you can use it them freely. So this is also from one of the journal. So you can see it is very popliteal vessel is very close to the lateral meniscus posterior root. So depending upon same way, so whenever you are doing lateral meniscus, so medial meniscus is very much amenable because there are not many dangerous structure on the medial side, but on the lateral side, so there are the common peroneal nerve, then again popliteal vessels in the vicinity. So there are various trajectory you need to choose. So when you are anterior to the popliteus tendon, then it is very easy. Risk of neurovascular injury is less. But posterior to the popliteus tendon, the risk is very much higher. So this is one video I'll be showing about the so that's posterior horn complex tear along with partial tear of root of the medial meniscus. So now I'm probing the tear. Now you see it is very much tight. So now I have made the pie crusting knee joint or medial space has opened up very well. Now tear is very much visible. It is like a flap tear as shown by the Dr. Amrish, and again horizontal cleavage type of tear. So now it's a patient was fairly young, around 22 years old male with a sports person with history of injury almost 6 to 8 months ago. So this age I'm debriding whatever the loose fragments. I'm trying to do balance out the meniscus. So sometimes you need to contemplate like if it is going to be unstable or not. Now you can see here after the proper balancing and giving thorough wash. Now meniscus is identified, tear is very well visible. So it is like a horizontal cleavage tear. So now I'm probing, I'm trying to see if I can pass the all inside device. So this is my spatula or protector, and that's so all inside device has come inside. It's 12 degrees up true span. So I'm just going and firing first device, then withdrawing slowly. Now because I just want to stabilize it, so I'll take a horizontal mattress type of fashion repair. So now I'm putting second device I'm deploying here. Now it has deployed. Now always I pass a probe so that it gives me, I try and give counter to that thread when I'm pulling. So the meniscus has been stabilized. So in this case, I have done partial meniscectomy, and whatever the loose horizontal cleavage that I have stabilized with the help of all inside device. Then there is another case where there is a radial tear, case similar to the one which we did live surgery, but this was very acute injury, and you can see almost bucket handle type of configuration, unstable, but it is not detaching. So here now sometimes we have to have combination of all inside out. So I try to, oh sorry, so I tried to stabilize it with all inside, because patient did not want any scar on the medial side if I'm going to do inside out. So with the help of diamond rasp, I'm debriding the tear so that hopefully some neovascularization occurs at that portion. Then I'm passing this all inside device in the center of the tear. So my plan was to put this one first, then one behind this, and one anterior to this. Now I'm withdrawing. I'm like taking vertical mattress type of configuration. Now I have deployed second device. Now what the why I'm showing this is because now everything looks okay. So I'm pulling the thread, and all of a sudden the thread has snapped. Now you see this thread has snapped here without anything. The orthopod now it has snapped. It is nowhere visible. So where was the stress riser? We don't know. Then now in this situation, my both the devices deployed and thread is lying free. So with the help of grasper, I'll try and pull it out and try and reduce it. Now even though I'm reducing it, I'm not happy with this. Now again, you cannot use suture cutter because very difficult to reach there. So with the help of shaver, I'm just removing the remnant with small shaving, whatever that remaining thread. Now the plan was to put another in the posterior to this, again all inside the same true span device with 12 degrees up. So now you can see because of that 12 degrees angulation, it is allowing me to go behind into the posterior capsule into the area where there is no tear. I'm firing first, now coming anterior to the tear. Now I'm trying to put another second device as much as away from the tear, again deploying it. So this posterior also I have passed one more device. Now again I have decided, so put another third one anterior to the trial. You can see my earlier the first one has already become loose here, because that's the reason I am not that much in favor of these all inside devices. And here you can see I'm going almost parallel to the tier. Both the devices I have deployed it in a parallel fashion. But even this trajectory gave me good reduction of the tear. So I'm closing the tear now. This has been stabilized. Similarly, again, lateral meniscus ramp also can be managed here. So here there was a ramp tear in the lateral meniscus, which I have debrided. It will be, so that's the ramp, lateral meniscus very close to the root. So I'm clearing out with the help of shaver, then debriding with the rasp. So that's the tear with the diamond rasp I'm debriding. Ramp of the lateral meniscus is very rare. So it is like a separation of the meniscus from the posterolateral capsule. So again, I'm passing my scope is into the medial anteromedial portal, and I'm passing this all inside device. So I'm just trying to get it proper trajectory. I was, I'm planning to go up, but I was not getting proper angulation. So I just bent the needle. First device is deployed. Patient had a ACL as well. And now I'm deploying the second device into the capsule, then reducing by giving counter with the probe. So it has been, sorry for the poor quality. The meniscus has been stabilized, the posterior, good fixation. Then passing one more device in a similar fashion. If it is not lateral meniscus tear, I mean in medial meniscus, I always supplement with inside out, whatever may be the case. I never solely depend on the out all inside. But in lateral meniscus, you have to be little cautious. So I always go for all inside for the lateral meniscus. Thank you very much. So I would like to invite you all for the 11th Pune course, which is scheduled for this month end. So we have almost 35 hours of academics and 17 live surgeries involving ligament, meniscus, cartilage, osteotomy, and everything in the knee. Thank you.